a great afternoon session lined up with 6 industry talks. Our first presenter to welcome is Amy Shea, Director of Diagnostic and Strategic Initiatives at Ionis, who will be presenting Ionis's ALS genetic testing program. Welcome, Amy.
Thank you so much. And thank you, ALS ONE, for including me and Ionis in this symposium. So my name is Amy Shea, and I'm the Director of Diagnostics and Strategic Initiatives at Ionis Pharmaceuticals. And I oversee all of our sponsored genetic testing and genetic counseling programs. Today, I'm going to give an overview of the Ionis ALS genetic testing program, as well as preliminary data from our testing program. The ALS testing program with Prevention Genetics out of Marshville, Wisconsin, was launched in March of this year. Prevention Genetics uses an exome backbone, allowing flexibility to add genes and mine raw sequencing data. It also allows for reanalysis when new genes are found to cause ALS in the future. We've initiated discussions to access and analyze raw sequencing data for research purposes. We have a designated geneticist expert for ALS at Prevention Genetics, who is also the clinical lab director, Luke Drury. Our program includes pre- and post-test third-party genetic counseling through Gene Matters, which is a Genome Medical subsidiary. The specimen types included for this are blood, saliva, and buccal swab. Saliva and buccal swab can be collected by the patient. Prevention Genetics has more detailed information on their sponsored testing page, including test requisition forms in English and French Canadian, as well as detailed program information at the below URL. So our program users include 81 unique testers, 23 organizations, and most of which are the ALS Centers of Excellence. Eligibility criteria for this program is a suspected or confirmed ALS clinical diagnosis or a family history of ALS for patients 18 years and older. The 33 gene panel is detailed on the Prevention Genetics sponsored testing URL website. And we know that panels may change as new genes become characterized. This panel is not carved in stone. It will evolve as the ClinGen recommendations develop. "31 genes are sequenced by NGS with an exome backbone. Our testing program runs all genes versus a tiered testing, starting with, for example, C9orf72, like some other programs. Orthogonal testing for C9orf72 and Ataxin-2 are also included. C9orf72 testing requires applicon length analysis for smaller or intermediate hexanucleotide repeat expansions, as well as bidirectional 5' and 3' repeat primer PCR generation sequencing panel to reduce false negatives from allele dropout. Ataxin-2 requires amplicon length fragment analysis and bidirectional repeat primed PCR to detect the presence or absence of CAG repeat expansion and can determine repeat sizes up to 40 trinucleotide repeats. Ataxin-2 intron 1 trinucleotide CAG repeat expansions between 29 and 33 repeats with a CAA interruption predisposes to increased ALS risk, increase in ALS FTD risk, but not isolated FTD. ALS patients with 34 or 35 or more repeats have been reported. CAG repeat expansion greater than 35 cause spinal cerebellar ataxia type 2, or SCA2, with 100% penetrance, usually with 37 to 39 repeats, but over 200 repeats are possible. Repeats between 32 to 34 repeats have incomplete penetrance for SCA2. Ataxin-2 repeat size between 33 and 39 can be associated with levodopa responsive Parkinson's disease. Repeat size, especially between 34 and 36 repeats, must be interpreted based on the clinical presentation. Demographics for age and gender in this data cut are mean age at testing, 61 years, and median age at testing, 63 years, both ranging from 21 to 88 years. The mean age of onset of genetic ALS patients is 59.7 years, and median age of onset genetic ALS patients is 63 years, both ranging from 32 to 77 years. Male and female, 216 and 199 respectively, so 52% male and 58% female. There was 6 genders not reported, and male and female pathogenic or likely pathogenic variant carriers then was 29 and 24 respectively. So 54.7% male and 45.3% female. The pathogenic or likely pathogenic total for this cohort is 53, which will be further discussed in the following slide. Demographics for ethnicity in this cohort had a total of 288 reported, 238 European, 15 African, 3 Middle Eastern, 15 Hispanic, and 17 Asian. In our results, there were a total of 421 ALS molecular genetic testing patients. 139 variants were identified in 29 genes. 54 were pathogenic, likely pathogenic, and risk alleles in 13 genes. 12.6% positive diagnostic yield, and 86 variants of unknown significance in 27 genes. So of the 139 variants in 421 patients, 233 are negative, and we still have 54 results pending. 54 pathogenic and likely pathogenic variants were identified in 13 genes in 53 patients. You can see that we have the most common seen in literature. And of the 86 variants of unknown significance in 27 genes, interestingly, a vast majority are in the more newly characterized genes. This will be a big challenge. We hope to continue to contribute to understanding the VUSs. This is the ancestry summarized for the 53 pathogenic or likely pathogenic variants. The greatest number of variants is in European, as this was the largest population tested. Therefore, we need to increase diversity and equity in our testing program, in all of genetic testing. As a reminder, one of the challenges of genetic testing is our genetic testing program, as well as genetic testing as an industry, is the variance of unknown significance. That's the variance that we don't have enough evidence to determine pathogenicity or benign variant, which is based on the stringent criteria established by the ClinVar database. This includes, but is not limited to, having available clinical data on multiple patients and submitters with the same variant, as well as other possible predictive models or expression studies, functional data. And then it's reviewed to determine criteria. So taking a closer look, patients with variants in multiple genes. In multiple genes with a pathogenic variant and a VUS is on the left-hand side. These patients may have a different clinical course. Does the second variant change the clinical presentation or possibly age of onset? This is why it's important to look at the whole panel, not just the most common gene. Notice here, there is much earlier age of onset as well. We don't know if this is significant, but we need to study more and make sure that we share the data. We also have on the right-hand side a 1-ataxin-2 homozygote, technically a compound heterozygote having one allele with 29 repeats and the other with 30 repeats. So something to note with this is that the CAA interruption contributes to the age of onset, and he is 75 years. We have 86 variants of unknown significance. Some patients have multiple. One VUS was found in multiple patients. So we need to continue to study and collect data and characterize these VUS because all of these patients have a clinical diagnosis of ALS. Is this causation or association? So pre-test and post-test genetic counseling by an experienced board-certified neurogenetic counselor are strongly recommended for all patients considering ALS genetic testing. And in this cohort, 1.4% requested sponsored pre-test genetic counseling, 4% requested sponsored post-test genetic counseling, 1.1% requested both pre-test and post-test genetic counseling. Genetic counseling also may be offered by the ordering institution. And just as a reminder, our program has third-party genetic counseling, if needed, available. I've also included guidelines in the speaker notes for reference on pre and post-test genetic counseling. So 8.6% of the patients have a variant in an actionable gene with a gene-specific clinical trial available. So our Ionis sponsored genetic testing and genetic counseling program in the first 6 months since launch have 36 patients identified with a pathogenic or likely pathogenic variant in ALS gene with a gene-specific clinical trial underway. So 25 for C9orf72, 7 for ataxin-2, 3 identified with SOD1, and 1 identified with FUS. So of the 53 pathogenic or likely pathogenic variants identified, 68% are actionable with a gene-specific clinical trial enrolling. So I just wanted to give some acknowledgements as well as share my contact information. Donna Bernstein is our Associate Director of Genomics here at Ionis, and she prepared all of the data and analytics for this presentation. I also wanted to acknowledge Dr. Drury at Prevention Genetics, as well as Kaylee Avello, who's the laboratory genetic counselor at Prevention Genetics, and our partner, Derek Stevens, who's our business partner at Prevention, and then Michelle Hearn, who is our lead partner for Gene Matters and also a genetic counselor.
Thank you, Amy, for the really informative presentation about this great program. We have a question from Dr. Benjamin Brooks. Is there any geographical predominance of FUS and SOD1 combined mutations in the same patient?
So I am going to ask that Donna unmute as a support person for that question. I know she has information specific to the Asian demographic for us, but Donna, could you unmute?
Not yet. That's an interesting question, and we're sort of just beginning our program, but so far we only have one FUS patient identified, and it was in a person of Asian ancestry. Which is not that surprising, but we'll keep our eyes open and look out for patients who have multiple variants. And there's a lot of reports in the literature of patients who do have variants, pathogenic variants in more than one ALS-associated gene. So that's why we think it's really important to be looking at the whole panel.
Yeah, thank you. I have a question about tracking families. Is that something that your program takes into account, that some of your folks might be from the same family?
Yes, that is absolutely, cascade testing is absolutely critical. And prevention has a route to be able to follow the family specifically. We don't receive any PHI. So it's really about making sure the providers that we speak to are aware of the testing program and that this is available to the families of a program. And again, having prevention receive that information, they're even able to do specific site analysis testing, in addition to, of course, the panel on the same requisition form specific to a patient's pathogenic findings.
And might that be a strategy that could help sort of disambiguate the question of association versus causation, right, from folks?
Yeah, I'll let Donna go ahead and comment. Of course.
We strongly encourage cascade testing and segregation studies whenever possible. Sometimes they're not that practical because you have incomplete family history data or family members all over the country or people who aren't sharing their information with their family members, which we also encourage. But segregation studies will be really helpful in helping to uncover the meaning of some of the variants of unknown significance. And I'm working with the genetic counseling community to try to share our data and collect information in case we have this information, but we just don't know it because we're in different institutions and they're not reported fast enough to ClinVar. So this is something we're actively working on.
And to that point of sharing data, can you ingest whole genome sequencing data from other groups, from other programs, and analyze them in a similar way that you're analyzing the data that you're generating?
So we're in the process of ingesting the raw sequencing, so it's whole exome. And we are not in a place right now where we're ingesting any separate data sets yet. And I think it's something worth exploring for research purposes, but it's something that Ionis, again, is always interested in doing our best to understand the findings. That right now it's with this particular cohort, and in the future partnering with different institutions or different data sets in order for us to better understand. Donna, do you have anything else to mention?
I'm not sure what I do, but I probably won't. There are other programs underway at Ionis that are thinking the exact same way, but they're sort of bigger than the scope of the ALS testing program.
And we have one more question out of the chat. Have you found any patterns between age of onset and certain genes or combinations of genes yet?
Go ahead, Donna.
Certainly, the patients who have a genetic etiology have an earlier age of onset. And I think, one of the slides that Amy showed is interesting, that it appears that some of these patients who do have a pathogenic variant on one allele, and actually I don't even know which are in cis and which are in trans, but have more than one variant, a pathogenic and a VUS, seem to have an earlier age of onset. But again, it's small numbers and anecdotal, and I wouldn't make any big conclusions yet, but this is definitely something of interest that we would like to learn more about too.
Well, thank you both for the presentation and for addressing the questions. And we're going to move on to our next speaker.